Now, portal hypertension is an extremely important concept to grasp. Now, first thing you just need to remember this simple anatomy. The portal vein carries all of the blood, all of the deoxygenated blood from the GI through the liver for detoxification, and then it goes to the inferior vena cava and back into the heart. Now, normally, the portal vein pressure is anywhere from 5 to 10 millimeters of mercury. If it goes up by even as little as 5 millimeters of mercury, we can develop portal vein hypertension or portal hypertension. Now, we have several causes. We have prehepatic. Prehepatic causes would be anything before the liver, so anything outside the liver. The intrahepatic causes would refer to anything that's going on inside the liver proper. And finally, the posthepatic causes refer to anything after the liver. So this can be obstruction anywhere between the liver and the right side of the heart. Because remember, our inferior vena cava is going to come and it's going to drain into our right atrium. Okay, so anything from there to here that's obstructed can back up and lead to portal hypertension. So let's talk about the specifics for each category. Now, the two main prehepatic causes, meaning anything prior to entering the liver, are going to include portal vein thrombosis, so if we have some sort of thrombus that develops in this vein that increases the pressure, it leads to a backing up of contents, would be caused by portal vein thrombosis. The second most common cause is just going to be a congenital atresia. What that means is that there's a narrowing within that vessel. So instead of looking like this, the vessel may look like this. And obviously that's going to affect the pressure within the vein. Now, intrahepatic causes can be many. The way you need to think about this, instead of just memorizing everything, is think about anything going on inside the liver that can take up space, that can make things harder, okay, or solidify the tissue within the liver. Now, the most common culprits will include cirrhosis, hepatic fibrosis, and under fibrosis you need to consider things such as Wilson's disease, you think congenital fibrosis, or even hemochromatosis. So there's a variety of possibilities when it comes to intrahepatic. And finally, posthepatic. As we said, this is obstruction anywhere from the liver, or the outside of the liver, right here, all the way to the right side of the heart. So common culprits may be the hepatic vein may be thrombosed, so hepatic vein thrombosis, or inferior vena cava thrombosis. You may have a congenital malformation of your inferior vena cava. Or some sort of constrictive disease of the heart. So any type of constrictive pericarditis. Okay, so as long as you know your basic pathology, you can kind of determine possible causes for each one of these, whether we're talking pre, intra, or posthepatic causes for portal hypertension. Now, when it comes to the signs and the symptoms of portal hypertension, this is one of those concepts that you can easily understand. All you need to do is think about this portal vein and think about what kind of symptoms will occur if blood is pushed back from where it came from. So if it escapes the liver and moves backwards, well, remember there's the concept we discussed earlier when we talked about hydrostatic versus oncotic pressures. Now, in this case, we're going to see a huge increase in hydrostatic pressure because there's so much fluid building up in this portal vein because there's nowhere for it to go. The hydrostatic pressure is elevated. So when we consider all the findings, consider what would happen if we push fluids out of circulation or back into other tissues from which they came. So we're going to see things such as ascites. We will see splenomegaly. We will see engorgement within all of the portocaval anastomoses. So if we consider all of those portocaval anastomoses, what we're dealing with is things like esophageal varices. And we know esophageal varices are very, very dangerous. Remember, these can rupture and lead to hemorrhage. And we control those with beta blockers in order to prevent them from bursting. We see gastric varices. We can see anorectal varices. We see caput medusa. And remember, caput medusa is seen around the umbilicus. Now, as I just mentioned, these anastomoses can lead to significant problems, such as hemorrhages if they bleed. Now, what we're worried about more often than not are the esophageal varices as well as the gastric varices. And we want to control these with beta blockers. And if this doesn't control the problem, then the management of choice is usually what is known as a TIPS procedure. Now, TIPS stands for transjugular, intrahepatic, portosystemic, shunt. Okay, TIPS. Now, this is going to create an artificial channel within the liver, establishing communication between your portal vein and your hepatic vein. So we want to bypass whatever's going on in the liver in order to reestablish a proper communication between these two. And what that'll do is it'll normalize pressure, and subsequently it'll relieve the esophageal and the gastric varices that we're worried about rupturing and hemorrhaging, and then we don't have to worry so much about that anymore. Okay, so the TIPS procedure is what we're going to do when we're worried about rupturing of those varices.